This is Karamjit Singh, Chair of University Hospitals of Leicester, and you're listening to the HSJ Health Check podcast.
Hello and welcome to the HSJ Health Check podcast. I'm Dave West, HSJ's Deputy Editor, and each week we are going to gather a cast from our team of expert journalists to explain and debate the most important news issues right now in NHS policy and leadership. HSJ Health Check will bring you a uniquely up-to-the-minute, robust and informed analysis. It will be available each Friday morning on the hsj.co.uk website and across all the main podcast channels. This week I'm joined by three of our core podcast team: Ben Clover, HSJ Bureau Chief for Efficiency and Performance, James Illman, Senior Correspondent for Brexit and Performance, and Annabelle Collins, our Workforce Correspondent. In each episode, we'll tackle 2 or 3 big questions from the week's news. And today, in our 30 minutes, we're going to ask, firstly, what on earth is going on with Brexit, and more importantly, what does it mean for the NHS? And secondly, are NHS services and patients feeling the benefit yet of the government's new £20 billion for the health service, which started to come on stream in April? First off, James, you've been following the latest Brexit developments in as far as any human being can actually do that. And I think we should perhaps divide this up into 2 questions for you. Firstly, in relation to the new tentatively agreed deal with the European Union, what's the upshot of that for the NHS? And secondly, given there's a new deal tentatively agreed, does the NHS now need to be ramping up, or should it be winding down its no-deal preparation? First of all, there's a new potential deal on the table. How's it stacking up for the NHS?
Sure. So the first thing to say is that if a Brexit deal does finally go through, we go into a transition phase. This in theory runs until December 2020. Ministers are publicly opposed to an extension, but a 1 or 2 year extension is possible. So this period could run on for quite some time. During that time, the UK remains fully aligned to EU laws. So a lot of the potential impact of a Brexit deal will not be instant. There is, however, consensus among the apolitical experts and NHS lobby groups that the NHS will be exposed to more risk by the government's latest Brexit deal than it was by Theresa May's original deal agreed back in November 2018. The main reasons can be split into 4 broad categories. We've got the economic impact, the impact on trade and how easy it will be to import medicines and other supplies into the UK, workforce, and the impact of a continued uncertain situation and the threat of a potential no-deal Brexit cliff edge, as far as trade is concerned, at least in the future, if negotiators can't agree a deal in the next phase of discussions. As we know, Brexit basically goes on forever. So on the economic impact, the government's not published an economic impact assessment of the deal. That's assuming it's even done one. So the most credible study that has been carried out is by the UK in a Changing Europe research group. So their estimates were that the public finances will be worse off by between 19 and 49 billion per year under the Johnson deal. That's compared to being worse off by between 13 and 39 billion a year under the May deal. So that gives a lot less fiscal headroom for things like social care reform. We also need to remember the potential knock-on impact of any economic impact on economic downturn on other areas of public spending like education, housing, the welfare system, also affect demand on the NHS. Then on trade, one of the NHS's biggest areas of concern about Brexit is the continuity of supply of clinical and also non-clinical goods after either a no deal or after a Brexit of any sort, really. Now, we know Brexiteers vehemently opposed the Northern Ireland backstop agreement in the May deal because it would mean the UK would remain tied into the EU customs union, and that would take away the chances of striking any new trade deals. But as an insurance policy for the NHS, it would have ensured the continuity of supply. So the NHS was fairly happy with that deal. This isn't the case under the replacement, under the Johnson deal, which is being referred to as the front stop and involves a customs border down the Irish Sea rather than north to south over the island of Ireland. Now, the Nuffield Trust's Brexit expert, Mark Dayan, told me this week that the front stop seems to set us on course for more trade friction than the old backstop. Under the new front stop arrangement, there's no all UK customs union with the EU. Again, modelling from the UK and a changing Europe, assumes barriers to trade would rise by 3% under a Johnson deal. That is, however, better than the 8% they assume under a no-deal scenario. So it would cushion the blow a bit. On the workforce, so the impacts on the NHS and also the social care workforce is one of the biggest risks posed by Brexit. In the longer term, the King's Fund estimates there's 116,000 EU nationals working in the NHS and around 104,000 in social care. Now, the withdrawal agreement secures the rights of EU citizens in the UK, but the government has consistently said that after Brexit, there will be freedom of movement will cease. So the workforce issue, it's not one that's necessarily going to explode on day one after Brexit, but could be more of a medium-term challenge. That said, senior NHS figures have expressed concerns to me over the last few months that some EU workers, especially low-paid carers, may go back to their countries of origin over Christmas and then not return to the UK. Now, at this point, I'm going to bring in Annabelle Collins, our workforce correspondent. Annabelle, do you want to just elaborate on some of that?
Thanks, James. So I think the workforce situation is quite complicated as alongside the Brexit negotiations, the Migration Advisory Committee is also consulting on what a future salary threshold would be. They're also looking at refining a visa point system. This has been quite well publicised, I think, particularly at the recent Tory conference. So that's causing, understandably, a lot of anxiety in the NHS as making that threshold tougher not only damage the NHS but also social care, particularly social care, as many staff are crucial but perhaps deemed below skilled. Also, we've published a story today which is actually quite interesting. It's based on some GMC data, and it shows that actually the number of international doctors is now bigger than the number of UK trained doctors working in the UK, and since Brexit
coming onto the medical register.
Yeah, joining the medical
more
register.
International doctors coming onto the register than UK trained ones, which is quite, as you say, it's kind of surprising given the kind of overall narrative of a potential sort of hostility or a change. Change of direction.
Absolutely. I think once you start looking at the numbers, and also if you look at nursing numbers as well, some of the UCAS data around nursing students coming over to study here from the EU and outside of the EU, there was a dip, but the numbers are starting to recover again, and I think the same can be said for medics joining the register from Europe as well. So it's not necessarily it's not all doom and gloom. I think that in a few months, when we have the outcome of the MAC's consultation, that will be perhaps when we see some real change.
Yeah, it's not a straightforward kind of equation there. Ben, you wanted to come in on this?
I want to make the point that probably the effect on social care shouldn't be underestimated, kind of given what the previous estimate of the minimum income would be. It seems unlikely that it's not going to cover social care stuff, and we know from the version of the Yellowhammer documents that got released that kind of at least 4 local authority areas would be in serious trouble if, as a result of leaving, we lost significant numbers of social care staff, because that's just for the NHS. That's just very quickly the hospitals being unable to discharge to a care home.
I mean, presumably this is a similar, perhaps not quite as strong, but a similar equation applies to a healthcare assistant, non-registered staff on which NHS clinical services are increasingly dependent as well.
Yeah, well, as HSJ reported this week, kind of the gradual change in the skill mix has really kind of solidified now. So HSAs, like most hospitals, are dependent on their HCAs, not HSAs, to do the basic work of care in what's going to be a really, really busy winter by all accounts. And I spoke to a hospital chief executive years ago and asked him what the most difficult thing in the job was, and he said it's persuading people to do a very difficult, demanding job of care when they could make just as much money doing a much less demanding shift, like on a checkout at a supermarket. And that's going to get even more difficult if we can't recruit those staff from overseas.
Yeah, no, I just add on that in that Keith Willett, when he's done these Brexit roadshows where he's been going around the country, and one of the issues that he did raise was the social care workforce, and elaborating on Ben's point a bit about the lower paid end of the spectrum, there's a real concern that over the winter period, in the run up to Christmas, some of these care workers will just go and take jobs in seasonal work, packaging and those kind of jobs. So certainly this winter, with or without Brexit, as far as the social care workforce, was going to be incredibly challenging.
Oh, so that's them taking seasonal work in the run up to Christmas. This is not just them not coming home after Christmas.
No, it's before Christmas as well, seems to be the concern. So, both sides of Christmas could be quite problematic.
And tell us, Oresti, you hadn't completed your really crucial analysis of the impact of that of the proposed deal for the NHS in other areas beyond the really important workforce one.
Yes, there was one point to add on that, and that's around this potential cliff edge in December 2020, or maybe beyond that if there's an extension. But as we know, the withdrawal agreement is not the end of Brexit, it's just the end of this chapter of Brexit, and then we run into a whole new set of negotiations around what the trade deal looks like with Europe. Now, if that can't be agreed within the period of the transition deal, then you've got a no-deal scenario all over again. Which could be incredibly challenging for the NHS, and it also leaves this kind of lingering uncertainty over the system, and we know that uncertainty is always a bad thing.
It feels like we're sort of people are putting in a heck of a lot of effort and kind of hoping that something's going to give way. Actually, even when it does give way, over the next few weeks or months, we're then going to enter a kind of period of just as intense, both lobbying and calculations and preparations for what comes next, to me.
Sure.
Just to add, on that point about uncertainty, I think we also do not have clarity on the future flow of staff post-Brexit. So, for example, currently the shortage occupation list is absolutely crucial when it comes to recruiting staff, nurses from overseas. So all nurses are on the shortage occupation list. As of this year, all doctors, a lot of allied health professionals, and there are no guarantees that this is going to remain the same over the next few years. It could well change. Maybe nurses won't stay on it. I think that's something, a future immigration policy needs to consider.
And the second part of this, the Brexit question, James, excuse me, from my perspective, is the no-deal preparations, either the current preparations which the NHS ramped up for March when there was the expectation of a possible no-deal, and then has ramped up again in recent weeks looking towards 31st of October. Now there's a tentative deal. Does that mean we can be, in reality, they can be winding that down?
Not at all. I think if you spoke to anyone in the senior levels of the NHS, certainly the advice seems to be prepare for no deal. Keep those preparations up to sort of cranked up to the levels that they're already at, which is a very heightened state of alert. So, as you said, Dave, we went into no-deal preparations in the run-up to the original March deadline, and then everything had to get ramped back down again and then ramped back up again for this October deadline. Now, the March deadline did kind of act as a useful rehearsal, and I think system leaders managed to see where quite a lot of the gaps were, and the NAO did a very interesting report about Brexit preparations, which came out in the last few weeks, and certainly it was fairly positive about the preparations that have been made by the NHS. But first of all, you can't prepare for the things that you don't know about, and those are potentially the issues that are the unknowns are going to be the things that could cause the biggest problems. Secondly, it's very stressful and tiring for the system as a whole. So when you've got parts of the workforce being told that you can't take holidays during certain points, well, that means lots of people working without holiday, they're going to have to take that leave at some point. That could mean it all stacks up at summer, and then massive staffing shortages then. But also it's just that working at that kind of high level of stress is tiring. And one of the Kent trusts, an area because of being by the short straits, could be particularly badly hit by Brexit. It's sort of talked about the concern of Brexit fatigue, and I think that'll be a concern for the whole system. If it has to stay on this kind of heightened state of alert for months on end, possibly even years, then it's going to be very stressful for the system, in addition to already a very stressful system with a tough winter coming up, off the back of a really tough summer.
No, you can't in reality be more prepared the entire time,
no.
Can you? Okay, coming on to our second question now, which is the NHS and its patients feeling the benefit yet of its £20 billion funding boost, which kicked in April? Quarter one figures were released this week, which prompted me to think about this. Quarter one financial figures coming in mid-October, somewhat later than previous years, and give us the first kind of picture of the financial lay of the land during 2019-20, since this 3.4% real terms increase in revenue came on stream. But I thought we could consider more widely the finances, but also whether staff and patients and the system as a whole are starting to see benefits from that money. And I thought I'd come to ask you, Ben Clover, first. What's your impression of how the NHS is, on the financial question, what's your impression of how the NHS's finances may be shaping up this year?
Well, the early indications are it's not that much better than last year, despite the extra money that's been put through. Like the projection isn't all that different. So we only got quarter one, so that ended in June. But as with almost every previous year, kind of the savings plans trusts are planning quite heavily backloaded. That's a problem, because traditionally backloaded saving plans are a bit less real. They tend to be less about and frequently missed. Yeah, I mean, there are still a lot of trusts out there kind of working to identify like a good 30 or 30% of their of what their savings plans are actually going to be. And as Lawrence, one of the other bureau chiefs, pointed out in his piece on this, kind of the savings last year were flattered by a number of one-off factors. So what we can see is, although trusts were told they would only have to work to a 1.1 efficiency target, i.e. they'd only have to make savings of 1.1%, it's actually looking like something around 3 times that, which is much closer to a situation trusts have been in
and gives a little
the previous decade.
A tangent, but I think this is always a niche but fascinating facet of NHS finances. Why is there an NHS efficiency assumption of 1.1%, but then the vast majority of trusts are talking about making 3%, 4%, 5%? What goes wrong with the assumption?
So the 1% was supposed to be a way of saying, look, we know this is what is actually possible. Right, so in the glory days of plenty of NHS funding, you could miss your efficiency savings target and still come in on a surplus, and that was fine. But the idea that you should be doing about 4% a year, and that was money was being taken out of a tariff to pay for that, was that you should be getting more efficient to deal with the increase in work coming through each time. In practice, lots of those savings just like simply weren't real over the past decade or so. There could be like things like land sales, which is not really a saving, or just doing more activity and getting paid more for it. It's not really a saving, or sort of accounting measures that people take. Like the classic thing would be to get your asset revalued, so as you pay a small amount of so as the depreciation works for you a bit better.
The system's saying we know about 1.1% is realistic, but actually is tacitly acknowledging that if we're going to get going to balance, then everyone would have to do more than that. Really.
Yeah. So it's not entirely clear where all the new money will go. Like some of it's been eaten up by just the promised pay increases.
Because just on the key numbers, the deficit that trusts providers have racked up in the first 3 months of the financial year is around 800 million, very, very similar to the figure in the past 2 years. So you're seeing as there is a bit more coming in, I imagine they would be keen to point out not vast amounts coming in given the pressures upon them, but it's sort of going somewhere, isn't it? And I think we have a bit of a feel for that.
Well, I think it's largely gone on addressing some of the things that some of the analysts and the think tanks have pointed out, that actually the 18-19 position was about a deficit of about 2.5 billion kind of in actuality as trusts, as you added up the trust position, which might be different to what was actually predicted at the start of the year, but the system started underwater basically. So a lot of the extra money that's being pumped in isn't going to feel like, hooray, we've got a load more resource. We've got a load more staff. We've got more theatres for them to do their work in.
It's sort of fixing the roof, although not literally because they haven't got the capital, but fixing the revenue roof.
The capital is a whole nother different issue.
But perhaps we should talk about that, because on the wider question of why doesn't it feel like is it going to feel like the NHS is getting relatively decent funding growth in revenue terms? Capital is probably one of the issues.
Yeah, and it's not going to feel like a land of sunshine and rainbows, because the backlog capital maintenance situation has been so bad for so long. Like the capital budget has been raided so many times, even below the low level that it was actually set at, that the most recent ERIC data put the amount of safety critical backlog maintenance at over $1 billion. I mean, it's been that way for this year and last year, but that's still twice as much as it was 4 years ago.
Probably a constraining factor on making staff feel better because of where they're working, on having patients having a better experience because the place is still full, etc.
Yeah, and it's like the hospitals are running very hot. Like and that's just the safety critical backlog maintenance I'm talking about, rather than the total backlog maintenance. All of which, that's kind of things like repairing the crucial power networks to actually make the buildings run, let alone things like that go towards staff morale, like just the general state of the estate.
Yeah, I mean, Annabelle, the staffing is crucial to this, isn't it? Because the NHS's million-odd staff, if they don't feel that something is better since April, then it's it's questionable that anyone else is going to feel that it's better with that money coming.
Absolutely, I think we saw staff on the Agenda for Change contract get a pay rise as of last year, but this pay rise was long overdue. So any good feeling towards it was perhaps to raise by years of not having a pay rise. I think the same can be said for doctors. There's quite a lot of bad feeling last summer with the new health secretary, Matt Hancock, announcing a pay rise, but then telling them it's not going to be backdated. I think actually the areas that staff are going to notice improvement are actually regional projects. So we've reported quite a lot on Milton Keynes kind of rolling out quite a substantial staff benefits program, spending money on building a new car park so staff can park free of charge near their place of work, which sounds like quite an obvious perk to a job, but actually in the NHS it's of constant frustration to people. So I think it's kind of making the day-to-day working life of NHS staff better is actually going to be where, you see the most improvement in the morale of staff.
Yeah, so maybe that over time that extra money does feed through to slight improvements in people's working lives. And what about ideally, or as envisaged in the long-term plan, the money would be used to provide a broader set of services to start, getting more people kind of diagnosed with or without cancer more quickly, treating more people for their planned surgery. But that needs the workforce to be there, and I wonder if that's one of the constraining factors now the money's come on stream, that it's quite hard for them to find staff to come and do the additional work.
No, absolutely. And there are certain pockets of the NHS staff where there's been long-running stagnation. So an example that springs to mind is psychiatrists, although we have very recently seen a 2% rise in the number of psychiatrists entering the register in the UK, which is really positive, but it's difficult to turn around quickly. The same can be said for many other specialties. Another one I'm thinking of are radiologists. We've published some quite interesting pieces recently about some kind of interesting pilots using AI to mitigate for shortages, and that's obviously very early stages, but I think we can potentially see more of that going forward.
Yeah, so you look into technology instead, but is it quite on stream yet? Certainly
absolutely, and it needs investment as well, as these things aren't cheap.
Certainly every time you kind of hear someone from Cancer Research UK talking, they're sort of, it's typically about, well, possibly more recently about capital as well, but about the staff that are needed to get diagnosis done, etc.
Yeah, and I also think about how the staff are used. So, making sure that people are operating to the top of their license, kind of looking at how you're using your nurses, how you're using your HCAs, and making sure that everybody is kind of working in the most efficient way, but also you're getting the most out of them, as ultimately somebody's going to be motivated, more likely to stay if they feel that they're working at the top of their license.
Yeah, so there's a lot of that work going on into this people plan we're expecting later on in the year. But one of the things that's kind of eaten up NHS money over the last probably decade, and then with decreases in the recent years, is the agency spend. Have you had a chance to look at the early signs of that for this year, Ben?
Yeah, it's interesting what's happened with agency spend. And agency spend always has to be sort of considered alongside bank spend, and they both represent work, like staffing need to do work over what the actual staffing establishment does in its regular hours. And there's been a big drive since like the Carter Review to try and reduce the amount of agency spending, and there's been some successes to that. Like there's been caps and things brought in, so people do say, oh well, the fact that it's going up again, we're still getting better value for it. But it's a real, I think, interesting indicator of the gap between of what you're rotated for and the work you actually have to do. So last year, the total bank and agency spend was about 5.8 billion, which, for context, is about half of a total mental health budget, like for all mental health services. Like 5.8 billion, it's a lot of money, but they'd planned for 5 billion. So even though quite a lot of that was bank, so they're saying that's better value, that's still a long way to miss your target. But this year, the plan that was in the quarter one forecast for 2019-20 is 5.4 billion. So that's quite a long way higher. That's 400 million pounds higher than was planned for last year. So maybe like an indication that we're going to see quite a lot of demand for work that's going to go unfilled, just because of the fundamentals of supply and demand in the workforce.
Yeah, and I think the other thing I should briefly mention in relation to where's the money going kind of question is there are the other asks on the system. There are things in the long-term plan that need to be done this year that will start taking money. So it's not so it cannot be expected to immediately go to the bottom line and get rid of that £800 million in 3 months deficit. But I just wanted to ask James one final thing for a quick thought on performance. And Ben's already stressed, but it is relatively early in this new 5-year funding settlement. But are we starting to see any kind of early signs of benefit to NHS performance from having that new money on stream?
No, not really. we've just come off what is the worst summer on record in terms of 4-hour performance. It goes back to about 2004, that data. To put it into context, so 4-hour performance was around 85% against a 95% target for the summer period. Now that's the kind of performance we'd usually see in the winter. And summer is usually when the system's been allowed to catch back up a bit and have a bit of a breather. That's just not happened. And again, in the kind of broader historical context, we've seen performance slip back. All the gains made during the noughties kind of crumbling away, and we're kind of at 1990s levels of access. Certainly no signs of improvement yet, and we're heading into what's going to be a very challenging winter. Demand is rising sharply. Emergency admissions growth over the 3 months up to September was more than 3.6%, and over the last 12 months it's grown by over 4.9%. So no improvements yet.
You can't claw these things back immediately, but we'll be taking a closer look, I think, over the next few months of where the new money's going, whether it's making a difference. All right, but we're out of time for today. So thank you very much, Annabelle, James and Ben, and thank you to you all for listening to our HSJ Health Check podcast. We will be here again next week, published on Friday, to download on hsj.co.uk and to access across all the major podcasting channels, Spotify, SoundCloud, and leading on Android apps and iTunes. If there are any issues you would like us to tackle, please contact me on Twitter, Dave W. West, or email dave.west@wilmingtonhealthcare.com. And please spread the word of our podcast, and see you next week.